Thank you, Sri Priya. Good evening, everyone. So, as we discuss now, the Community Nutrition Forum, we all know it's a registered body, and we have started by a group of dietitians in 2021 across Kerala. And the main objective of CNF is to educate, elevate, and empower dietitians, and thus to eradicate nutritional illiteracy for a better tomorrow. Also, we provide a platform for community members, healthcare professionals, and experts in the field of nutrition to share their experiences and challenges related to nutrition. I would like to extend a special welcome to our esteemed guest, Dr. Usha ma'am, who is a renowned expert in the field of endocrinology and diabetes. She has graciously accepted our invitation to share valuable insights on the challenges of maternal health. I'm delighted to welcome our President, Ms. Sharon Thomas, our Secretary, Dr. Sri Priya Shaji, to the meeting. Due to unavoidable reasons, our Vice President Uma Kalyani and Treasurer Jyoti James couldn't join us today. So we are grateful to all of you for your tireless efforts and dedication to making this forum a big success. I would also like to extend my warm welcome to all the attendees who find time after a busy day. On behalf of CNF, it's my pleasure to welcome you all to the December 2024's last Dietopedia session. Thank you everyone for joining us today to gain knowledge and share your experiences. Thank you everyone.
Thank you so much, Sonia. So at the moment, I would like to introduce Dr. Usha Sriram to most of you must be knowing her and have attended many of her sessions. Still, we thought we should give her a small introduction to her. Ma'am is a physician, endocrinologist, and a diabetes specialist. She is also medical ethics expert, and she is a wonderful communicator. She is women's health promoter and women's right activist. She also had founded, she is actually working as a HOD, heading the Department of Endocrinology and Diabetes at Voluntary Health Services, Chennai. Apart from that, she is also a founder of DIWAS and director of Acid Health. Dr. Usha's education in medicine began in the prestigious Madras Medical College, and she has garnered gold medals and certificates of honor in her subject. She credits her strong foundation in clinical medicine to her outstanding and inspiring teachers at the Madras Medical College. And she continued her training in internal medicine and endocrinology and metabolism in outstanding programs in the US and obtained her American board certification in both internal medicine and her specialty endocrinology, diabetes metabolism. She also completed her graduate training in medical ethics, a lifelong passion of hers. She received the Auto Squad's Teacher of the Year award in first year. She began her career. In 2001, Dr. Usha began her research activities and has been the principal investigator for numerous trials on osteoporosis, diabetes, pediatric endocrinologies, in addition to her own initiatives on gestational diabetes, osteoporosis, childhood obesity, and polycystic ovary disease. Dr. Usha has been the executive committee member of Indian Society of Bone and Mineral Research for over a decade, and last year became the vice president of the society. There are many things to talk about Dr. Usha ma'am. I don't want to steal her session time. So I humbly welcome ma'am, and I'm very, very thankful for accepting to give us a session on her busy schedule. Thank you so much, ma'am. And really, we are a great fan of not only your sessions and also for the work you are doing on women's health.
Thank you, Sri Priya and Sonia, for this very kind introduction, and I'm delighted to spend this time with all of you. And please, I also want to say that let's keep it a little bit informal so that any questions that you have, you can put in the chat box or we can discuss at the end. Because at the end of the thing, there should absolutely be no doubts in any of our minds about at least these important areas in maternal health, generally about obesity, about GDM, about PCOS, and and what these things can do to the pregnancy outcome and health of the offspring. So can you share turn on the sharing? It says, okay, wait.
Ma'am, I want to share one small thing, which is unofficial. Inspired by you, I have also founded a Women's Mental Health India, in which we are giving pro bono counseling for women, especially in the lower economic status.
Fantastic. That's absolutely wonderful. Let's go through this, quickly. Screen sharing, yes. Okay, this is just, I had an introduction slide, but you've already introduced me. And what we are going to talk about is what all of these conditions that, whether it's PCOS or GDM or maternal obesity or lack of preconception care, which largely is preconception nutrition, which is why this is so relevant, whether the mother is overweight and in our country underweight, having micronutrient deficiencies, and not having food diversity. So many things that are going on in our in that hidden hunger. All of those things are happening in our women. It not only has an impact on the mother, both in the short term and long term, on the pregnancy outcome itself, meaning they could have a preterm delivery, uh, miscarriage, or having gestational hypertension, gestational diabetes, or they could have a stillbirth. And importantly, what we are learning is that it has an impact on the offspring. And we always thought that the impact was like, the first 1,000 days and, the infant health. But now we are learning that it can have very long-term impact, especially on neurodevelopment of the baby, including producing things like learning difficulties or ADHD or even autism spectrum disorders. And in the future, the baby can have chronic diseases like type 2 diabetes or cardiovascular disease. So there's a very big concern about maternal health. And there's a famous expression, the womb is more important than the home. And I think that's becoming, true by the minute. So if you look at some pre-existing phenotypes, take a woman who is overweight or has high blood pressure or some form of dyslipidemia or any degree of glucose intolerance, then during the pregnancy, they could have any of these things which I've already listed. And then they may go on later to continue with obesity or all those complications. From glucose intolerance, they'll go to fat diabetes, metabolic syndrome, and all of these things will lead to cardiovascular disease. And then there is another very important thing that we should know, which is if something can be corrected, it can only be done very early. And that's what we call plasticity, which you will see in green, the plasticity. It is the highest when, pre-conception and during pregnancy. And then as we, go later and later into life, you will, the plasticity will go away and there will be an inadequate response. But what this lovely slide shows is with each pregnancy, you put the mother in a higher risk trajectory than a person with a normal pregnancy. The same thing with the baby, with the NCD risk in the first offspring, and then, of course, subsequent offsprings as well. So first pregnancy has GDM, the mother has a 10-fold increased risk of future type 2 diabetes. Second pregnancy has GDM, she has a 15-fold increased risk of type 2 diabetes in the future. And when we say future, I want to make it very clear here, we are not talking about 30 years later, 50 years later. We are talking within the next 5 to 10 years. So if a mother is in her 20s or 30s when she's having her first GDM pregnancy, she could develop type 2 diabetes by the time either of her next pregnancy or within the next 5 to 10 years. And when she'll still be only in her 30s or early 40s. So why we have to focus on women of reproductive age is because of this. Women of reproductive age, India is the yellow, the mustard line right at the top. By the year 2040, 2050, we are going to have so many more millions of women in the reproductive age. Already, do you know how many women we have in the reproductive age? 332 million, 33 crores of women are between the ages of 15 and 49. That is the women of reproductive age. So we are among even South Asians, we are a very high group where the numbers are going to increase a lot. So there is a paradigm shift we have to approach. For example, suddenly one morning, a woman gets, she becomes pregnant. She cannot become a healthy mother. She had to have entered the pregnancy healthy. For that, she has to be a healthy young woman. And for that, she had to have been a healthy young girl. And for that, she should have be born a healthy baby. So do you see how this cycle is? Suddenly one morning you can't wake up and become a healthy pregnant woman, which puts a heavy responsibility on dietitians and public health people and community activists, women's health activists, to promote the health of, at least let's look at adolescent girls. At least let's look at pre-adolescent girls. If they become healthy, this woman can enter a pregnancy healthy and therefore have a healthy baby, which can then become a healthy young girl. So what all this came from is this person, David Barker, and we call this the Barker hypothesis. And this is the very important for us to know. It's called the developmental origins of health and disease. It's a hypothesis that proposes that environmental condition, when I say environment, the maternal environment, it could be maternal nutrition, number one. It could be maternal infections. It could be other stresses. It could be exposure to smoking or pollution or so the maternal environment. During fetal and early postnatal development will influence lifelong health and capacity through permanent effects on growth, structure, and metabolism, the phenomenon called programming. So what programming will do is, as the baby is growing, right, if the mother's malnourished, so the baby doesn't get enough nutrition. And therefore, the baby's liver and lungs and pancreas and kidneys and heart, all of them, they become smaller. There are less number of nephrons, smaller size of this and that. So this baby will be okay inside the mother with this small kind of, the less number of nephrons and smaller size. But this baby will, once it comes out, the natural tendency of all of us, and here nutritionists can play a huge role. Mothers must be encouraged only to breastfeed, exclusive breastfeeding for the first 6 months, and then complementary breastfeeding for another 1 year, so up to 1.5 years. This is the only thing that will protect this child from being overfed. See, if you're giving bottle and if you're giving all those, formula, you can just keep on giving a bottle. A breastfed baby usually will not overdrink. So I think you all should really push for breastfeeding. And I'll tell you later about the benefit of breastfeeding on GDM mothers. So just look at the mothers who are pregnant nowadays. They are older, heavier, come in with a lot of comorbidities or what we call multimorbidities. They are under more stress. They may be sleeping less, especially if they are working in IT industries and all that. And just to show you, when women walk into a pregnancy, the kind of multimorbidities and more one or more nutrition risks that they are facing. Some of them are facing, 2 or 3 risks and all that. The blue dot is India, and if you see among underweight mothers, we are the leading, and under anemia, we are leading, and we are not leading, but we are right up there. And even among overweight or obese, even though it says only, like 10-15% of them, given the number of pregnant mothers that we have per year, 40 to 50 million, 25 million babies are born every year. So when you look at those numbers, the entire population of Sri Lanka is less than the number of babies who are born in our country per year. So now you see how big of a problem we have in all these areas. So moving into this, very big problem called diabetes, which is, as you can see, they are projecting these numbers, but already by 2024, actually 2021 data, and now they're saying they're having 537 million people already. So this 642 will be reached long even before 2030, not this 2040. A very recent Lancet publication has said that already the world has more than 800 million people. It was published on World Diabetes Day. And they're saying India already has more than 200 million people. And why this is important from a women's health and women's nutrition and heart health is each of these things, whether it's diabetes or high blood pressure, obesity, dyslipidemia, all contributes to heart disease in everyone, men and women. But look on the left side and look on the right side. Women have very unique risk factors: gestational diabetes, hypertensive disorders of pregnancy, preterm delivery, PCOS, lupus, autoimmune disorders, premature menopause are all risk factors for heart disease. We never think of them as risk factors for future heart disease. Then look on the right side, psychosocial risks, socioeconomic deprivation, intimate partner violence, all of these things. And when we say environmental risk, air pollution, climate change, endocrine disrupting chemicals, all of these are big risk factors for women's heart health. And so if we want to approach women's health throughout her life course, we have to look at each phase of her life. And as you can see, most of it has to do with nutrition. So in fetal life, we can't do much about socioeconomic status. The government has to do about that. Maternal nutritional status and obesity and fetal growth. And as you go along, a lot of things are due to the diet and obesity and lack of physical activity. This previous slide, I want to highlight this, that over the years, in all our medical textbooks also, we've always looked at as if you want to talk about a prototype, right? It's always been like a 70-kilo man. They've never looked at women as women were not included in research. Women's issues were not paid serious attention to. And I'll tell you what that has led to. Of course, first addressing obesity in women. If you look here, there are more women who are obese, both in, earlier on in 2015 and going on to this last NFHS 5, but I'm not sure if everyone knows, because I learned about this fairly recently, that NFHS, National Family Health Survey, we always thought it's like the National Family Health Survey, right? They're surveying everybody. They're not. They're only surveying women up to age 49, 15 to 49, which is women of reproductive age. So the NFHS is really a survey of women of reproductive age. And most of the people they have surveyed are women, only a smaller number of men for comparison. So all NFHS data is purely about young women. So 24% means, my goodness, quarter of the women are obese. Okay, they've used a BMI of 25. Okay, and BMI of 25 we know for Asian Indians is obese. It's not overweight. So if they've included overweight also, it might have been more. So why are women becoming more obese? Nutrition transition, less active, changing lifestyles. More women have gone into the workforce, and the work is like this picture that I've shown you. Changing societal norms, and food industries, heavy advertising and heavy production of everything, that the advertisements, also. So the reason why women are, gaining a lot more weight. But in addition to all this, women have this problem. So here, dietitians can play a huge role. Women during pregnancy and after delivery. During pregnancy, I do not find most of the obstetricians advising women on what is the weight they are allowed to gain, and in each trimester how much they should gain. Most of the women who consult me for GDM or other things don't know that information. We have to tell them, and that is based upon the IOM guidelines, Institute of Medicine guidelines, and we calculate their BMI based upon their pre-pregnancy weight. Just before entering the pregnancy or the first booking, what was their weight? What's their height? Calculate the BMI. And based on that BMI, up to 18.5 is low weight, 18.5 to 23 is normal, 23 to 25 is overweight, 25 and above is obese. For each of them, there is very specific amount of weight they can gain throughout the pregnancy and in each trimester. So dietitians must become very strict with that. We cannot give this half sugar, kind of advice that is very casually been given. So very strict. And also after delivery, the problem in that, not problem, this the challenge in Indian culture is we go to our mother's house, and then the mother is taking care of the baby, mother is feeding this mother. So the grandmother is losing weight, but the young mother is gaining weight. So this is a problem that we are seeing all the time. And all that does is, by the time they go to their second pregnancy, many have developed frank type 2 diabetes if they've had GDM. Or subsequently they develop this. So let's keep this unique problem that women have. Then women also have problems with, they don't have the agency to do what they want. There may be depression and stress, and therefore they may be eating also to overcome that kind of stress. So that's another reason women may be gaining more weight. But what is all this weight doing to the woman? As I've said earlier, we never thought that obesity in the mother can cause these problems. Look at this. It can cause recurrent miscarriage. It can cause birth defects, spina bifida and neural tube defects, lower IVF success, miscarriage, CV anomalies. If in the late pregnancy, they develop all of these other problems, gestational hypertension, gallbladder disease, and preeclampsia. then the baby can develop a whole lot of problems during delivery, shoulder dystocia, macrosomia, then childhood obesity. And if they've had an operative delivery like cesarean section, we also know that that alters the gut microbiome. And the gut microbiota may be altered if the baby does not take in the mother's vaginal secretions and the bacteria, and therefore they end up they've shown that obesity may also be linked to that. And this is another data that shows how obesity in the mother not only increases all those things I showed you, also increases postpartum depression. They also have they have difficulty with lactation. Obese mothers have trouble with breastfeeding. So that's another thing that they need to know. And when we say obesity, we are always thinking they have to have a BMI of 35 or 40 and, big obesity. But look here, even maternal BMI of 25 increases the risk compared to a maternal BMI of 20. So any degree of obesity in the mother has poor outcomes in pregnancy and poor outcomes. And just to very quickly say that there are very important mechanisms which can be at everything from a molecular level to levels like where we are seeing inflammatory markers like interleukins and TNFs and all that, which are increased in the mother, which is really what is driving all of this. So we understand how a mother's obesity can cause a baby's neurodevelopmental disorders or cardiovascular disease is through these mechanisms. I'll quickly jump through this. And so I've already mentioned to you about gut microbiome, how a normal pregnancy, normal gut microbiota can lead to a healthy metabolic outcome, whereas in an obese mother, her gut microbiota can change the fetal gut microbiota and therefore have adverse metabolic outcomes in the baby as well. Now, coming to gestational diabetes. Gestational diabetes is in my practice, a complete nightmare because compared to the time I started practicing a few years ago, 20 years ago, I find the numbers have increased dramatically, and it is present in women that I least expect for them to have. It could be a vegetable vendor's daughter, it could be a CEO's daughter, or it could be a IT worker, it can be a housemaid. Everyone is getting GDM. So, and also at a younger age. It's very important that and on the left side, you can see the risk factors. They say advanced chronological age. For GDM, that age is more than 25. But even mothers younger than that are getting it. Family history of diabetes, other genetic factors. The South Asian race, the Indian race, we are at high risk. And then socioeconomic conditions. Very strangely, in India, in 7 of the major metros, the poor have more diabetes than the rich. So we need to keep that in mind. Somebody who's already overweight, sedentary lifestyle, polycystic ovary syndrome, there's a link with vitamin D deficiency, adverse birth conditions of the mother, meaning if the mother was born small, her daughter has greater risk for gestational diabetes. If the mother had GDM, the daughter has greater risk for this. So all that we have to keep in mind. So the risk factors are all increasing. And I want to show you this very good study that came from this is the CARS data, shows how in Chennai, young women are having this 20 to 24, that group is having pre-diabetes, so much of it, 35% pre-diabetes in young women, which will translate into gestational diabetes. So a mother who has gestational diabetes, her long-term complications are type 2 diabetes, cardiovascular disease, obesity, ophthalmic disease, renal disease, and some link with possible breast cancer, possible uterine cancer. That one is still, something that is being looked at. Immediate complications, of course, increased risk of preeclampsia, eclampsia, prolonged labor or dystocia, operative deliveries, surgical complications, postpartum hemorrhage. For the baby, a lot of things. I am most worried about cardiovascular mortality in the baby, neurodevelopmental outcomes. Immediately, of course, they can have, birth injuries because of the size. Indian babies, anything more than 3.5 kilos is a big baby. Because our average birth weight is 2.9 kilos. And 2 standard deviations on either side, we have to be careful. Below 2.5, small baby, 3.5 and above, big baby. So just to show all this fatty liver and kidney disease, all of these are associated with, women who have gestational diabetes. Also, recent work done from SRM University, where they've shown that exposures to endocrine disrupting chemicals like BPAs and dioxins, phthalates, parabens, all have been associated with increased risk of, there's a mRNA alteration in the placenta, then there is epigenetic modification in the placenta, which leads to increased risk of gestational diabetes in the mother, and therefore all the other complications that we already talked about. But what can we do as dietitians and physicians is we have to encourage women of childbearing age from 15 onwards not to be using plastic bottles, not to be handling plastic, not to be touching this, the printed, cash receipts and all that. And then, to be careful about cosmetics and other things, all of which have been linked to these things. And of course, fruit and vegetables, everything has to be, washed properly. We don't have to buy organic, but we can. Consequences of gestational diabetes, I've already outlined that, but just want to add 2 new things. One is even chronic lung disease has been shown to happen in the offspring of women with gestational diabetes. Now, like I said, they can be born too small or too big. They can have lung issues. This is all the babies, by the way. There is now new data to show that there is cardiac disease that is happening in the children, and of course the neurodevelopmental things which I have discussed in detail. Now, if the mother has both gestational diabetes and she is obese, can you see how the whole thing becomes, the environment completely changes because of oxidative stress and impaired mitochondrial biogenesis. It's happening in both places. So that combined together, they can have major consequences. So moving to how do we counsel these women with gestational diabetes? So I think the very first thing is answer all your questions about what is gestational diabetes, how did I get it, what are my risk factors, those kind of questions. Then very, very important is to know what is their pre-pregnancy BMI, followed by what is their weight gain allowed, followed by dividing the macronutrients for the day, breakfast, lunch, dinner, a couple of snacks. We don't want to really put any pregnant woman on a weight reduction program. We don't want to put them on some fad diet. We don't want to put them on intermittent fasting, because we already know during pregnancy, mother is, even fasting at night, many times they can wake up and have ketonuria because the baby is getting the nutrition through the night. So we don't want to do all of those things. Breakfast, lunch, dinner, 2 snacks in between. They usually handle the carbohydrate better as the day goes along. So you want to give less carbs in the morning, little bit more in the lunchtime, and maybe a little bit more at dinner. So you distribute it. And obviously, adequate amounts of protein and fat. The recommendation is they should get at least like 135 grams of carbohydrate a day. So all this has to be factored in addition to what they can afford, what they like, what is their belief. All, if we cannot give a pre-printed sheet, that doesn't, I find that that's not very helpful. Really important just to take a quick history. What is your typical day like? Morning, from the time you wake up till the time you go to bed. What do you eat? What do you drink? And who's cooking the food? Who's buying the food? How many other people are in the house? And then divide it up for them and give them an idea of what kind of snacks they should have. And I think it's very important to set those weight gain and other boundaries right at the beginning. Otherwise, this gestational diabetes weight gain is going to be a major challenge for for dietitian. I'll answer any questions you have at the end. But quickly, I want to tell you about PCOS and metabolic syndrome. Very big problem again in women and maternal health. So metabolic syndrome is this cluster of visceral adiposity, hypertension, high triglycerides, low HDL, some degree of insulin resistance. All of this put together is the metabolic syndrome. And when a woman has metabolic syndrome, it's very difficult because we don't measure the waist circumference. Waist circumference is the best, in my opinion, best physical exam anyone can do, because immediately it will risk stratify the woman. So measure the waist circumference. In Indian women, it can't be more than 80, non-pregnant women. And if she has any degree of glucose intolerance, HDL is below 50, triglycerides are more than 150, already you have fulfilled the criteria for metabolic syndrome, and they have poor outcomes. Just see this. Every one of these, whether it's blood pressure, they can have GDM, they can have small for gestational age babies. All of these can happen when a mother has metabolic syndrome. I've shown more preterm birth, preeclampsia. Uncomplicated mothers are on the lower panel, and you can see these other conditions that we are talking about are much more prevalent, like preeclampsia and GDM and small for gestational age. So before I go to PCOS very quickly, I just want to say we have been very, very myopic about maternal health, meaning all that every one of us wants, the obstetrician, the dietitian, the endocrinologist, is mother to have a healthy baby and go home. Then out of sight, out of mind. All the things that is actually, there is a storm brewing during the pregnancy, and the mother, both short term and long term, is going to face the consequences of that storm. We are absolutely not only aware, I think we don't care. We just want a healthy baby to be handed over to the mother and move on to the next pregnancy. So the answer to all of the things that I have talked about so far is preconception care. So because most pregnancies are unplanned, women enter pregnancy older, heavier, with more nutritional deficiencies, metabolic problems, all this environmental pollution, unhealthy behavior, mental stress. And the first 8 weeks are the most critical for organogenesis. And which woman is coming and seeing a doctor before 8 weeks? And any treatment that is done, this is all evidence for that, any treatment that is done after she walks into a pregnancy has not been shown to be of benefit because the window is closed. Interventions after the start of the pregnancy have not yielded the required results. And I already mentioned the Barker hypothesis, very important. And pregnancy is a stress test. It's a window to future chronic disease. So optimizing maternal health should be done before pregnancy. So maybe if your NGO can start focusing on women before they get pregnant, and I'm saying empowering them with knowledge of things. Otherwise, whatever happens in the beginning over there is going to have an impact on all of this. And each of these complications that we're talking about in pregnancy has an additive effect. You add one to the other. A hypertensive mom has a small baby, her risk of heart disease is much more. So there is an additive effect of each one. So that's another reason why we have to pay attention to all of these things. Now, let me go quickly to PCOS for a minute, and then I'll stop and answer your questions. I think the wrong way. Sorry. Keep moving. One more. Yeah. So
Can you increase your volume? It's like
yeah, my volume is at maximum. I think I'll just move closer to the yeah. Okay. So look at this girl. She's 17 years old. She comes with her mother for evaluation of hirsutism and weight gain. She's born full term but weighed only 2.4 kilos. Uneventful childhood. She attained menarche at age 12. Next cycle was 10 months later, and subsequent cycles every 3 to 4 months. Most of the time after giving a tablet for progesterone withdrawal. And her LMP was 4 months ago. Then she also started gaining weight, and by age 11, she was frankly overweight. And on exam, her BMI was 27. She had acne, upper lip hair, and all that. So we all know it kind of looks like PCOS, irregular menstruation, acne, facial hair, hair loss, overweight. All of these things are there. They can also have sleep apnea, eating disorders, anxiety, depression can also be there. So first thing is PCOS a gynecologic problem? Definitely not. It has major metabolic complications, major nutritional impact like eating disorders, body image issues, all of those things we have to keep in mind. Major psychological problems in these girls. You think it's a rare condition? It's not. As much as, anywhere from 8 to 20% of women of reproductive age can have PCOS. They can be obese, or you can have the lean PCOS variety also. So for evaluation of a woman with PCOS, the most important thing that we have to do are fasting sugar, 75 gram GTP, lipid profile. You do a TSH to rule out thyroid dysfunction. If they're having hirsutism, you're going to go ahead and check testosterone, 17-hydroxyprogesterone. If there are no periods, of course, FSH, prolactin. One of the things I want to mention to dietitians is never order insulin levels, post-glucose insulin levels, HOMA, none of those things. The professional societies have said we don't need it. So we should not be doing insulin levels in patients with PCOS. So, please don't order any of those tests. It's not a simple hormonal problem, as you can see from this cartoon. Multiple things are going on. At the pituitary level, some, GnRH pulse frequency is changed. At the, ovarian level, that there is, anovulation and androgen production. But most importantly, we have now learned that there is a post-receptor defect and therefore insulin resistance. Can it be diagnosed easily? We have to have 2 out of 3 criteria: irregular periods or no periods, either male hormone excess physical findings or a blood test of elevated androgens, and polycystic ovaries on ultrasound. 2 out of 3 only are needed to make the diagnosis. We should not be doing an ultrasound in young girls up to 8 years after they attain menarche. Very, very important. You can only say they are at risk for PCOS and do the ultrasound only 8 years later. So this also has to be kept in mind. And depending on who sees the patient, we might be, making the wrong diagnosis. This polycystic ovaries on ultrasound, 25% of normal girls can have it. We must keep that also in mind. And many times patients will come and tell me, I had it last year, I don't have it this year. My answer to them is one of the ultrasound is wrong. You can't have it last year and not have it this year or the other way around. It is always there. Okay. It is not a problem of overweight girls. It can also be present in underweight. So this same girl, she's been on metformin with regular cycles. She exercises regularly, eating healthy. Weight loss has been remarkable. Feels motivated. She and her dietitian are working well together. However, and she has considered oral contraceptive pills for her hirsutism, but because of obesity, they did not use that. So she's moving on to a job in the IT sector. Then, of course, things became a very big problem. She gained some more weight after that. And there are so many diets, can you see, that we can prescribe a patient. You're all dietitians. But here again, I'm going to stick my neck out and say something to all of you. There is no such thing as a PCOS diet. Anytime we say these things to patients, they actually have unrealistic expectations. And when things don't move in the right direction, they get, very upset. So it's best that we don't, a healthy diet, low carb, higher in protein, high fiber, and, lots of, vegetables, fruit, nuts, seeds. All of those things are the best kind of diet. A Mediterranean diet, so to speak, is really, and a weight reduction one is the best kind of diet that and obviously completely to avoid, all of these kind of foods are very important. There are a million cookbooks for, PCOS. I'm not sure, I really haven't studied any of these books to comment on it. Maybe we can talk about it at the end of this. But what is important is not to go on any kind of supplement or any kind of booster to reduce weight. There is no such thing, and we should not be using it. As an endocrinologist, what do I think of the new drugs like semaglutide or these weight reduction tablets for PCOS? So lifestyle. If that hasn't worked, or if somebody has got severe comorbidities, only then, even in a person without PCOS, somebody with obesity, I consider pharmacotherapy, because usually if you go the pharmacotherapy route, it's not in short term, it's long term. We have to be very careful about who we prescribe what. But most importantly, we have to prescribe also active lifestyle to these women. And that is very, very important in our clinic. So both PCOS and GDM that we have talked about today are very much, it's very difficult to manage, because we can prescribe something, but when they go home and do what they do is in their hands, right? So it's important that we say things that is doable and something that they understand, and something sustainable, and something that is culturally appropriate. We cannot be prescribing avocados and broccoli and Brussels sprouts and quinoa to an Indian girl who is used to eating, sambar and poriyal and idli dosa and all that. We just need to modify those things as adai and pesaret and our foods, millet dosas and all that, rather than prescribing some fancy foods. So I'll stop here, Sri Priya, and answer any questions, because this is an ocean in itself. I can, we can keep going forever.
Thank you so much, ma'am. Ma'am, before going to the doubt session, I just request all of you to quickly open your screen, like video, so that we can have a quick screenshot. Thank you all for joining us today. It is very nice seeing you all. Many of our senior dietitians are here to listen to you, ma'am.
Okay, so there is one question here. It says, please inform difference between.
Ma'am, can you just start your video? Just 1 minute, I can take a screenshot. One more smile, please. Thank you all. Ma'am, yes, ma'am.
So it's a very good question. It says difference between PCOS and PCOD. It's only PCOS. There's no PCOD. PCOD is polycystic ovarian disease or disorder, and that actually already a condition that is very stigmatized. We don't want to use words like disease and disorder and all that. So abandon PCOD. It's only PCOS. Second question is, lean GDM is increasingly common, especially in the second trimester, and glycemic control is challenging. Could you discuss key points to keep in mind for better management? A very good question. So it's always like a high wire act. You want the mother to gain the weight. You want the sugars to be in control. You want the baby to gain the weight, right? And for her to be satisfied with the food. So all of those things we have to work together. So if the mother is not gaining weight, definitely revisit what she's eating, because a lot of people, the moment you say that you have gestational diabetes and you put them on a diet, pendulum will go the other way. They'll stop eating. Or the family will cut down their food. So this woman will not gain weight. So weight gain is also very, very important. And the baby has to grow. So make sure you revisit the diet. And if necessary, we can give insulin. So these are the women we should not give metformin. Because metformin decreases weight gain in the mother and the baby. So one of the side effects of too strict a nutrition or adding metformin has been small babies. So the diet prescription is very important in GDM, and that's why I said we have to take a detailed history and go through it and make a diet plan for them. One size absolutely cannot fit all. Does seed cycling help in PCOS? I'm going to say no, because see, PCOS is a genetic condition. PCOS has got multiple hormonal, the pituitary level, the adrenal level, ovarian level, liver level, and all kinds of issues. So if you think about it, what can seeds do to fix all of these things, right? Definitely incorporate seeds and incorporate and seeds and nuts and fiber and all that in their diet. See, and another thing that can happen anytime we prescribe something like this, right? Obviously the woman is very concerned about her weight and concerned about the PCOS. They'll be doing other things to improve their health. So we don't know which one is helping. And there may be just some, nutritional components in the seed that are helpful, which is going to be helpful if they just include nuts and seeds in their diet. Because I'll tell you what my concerns are. We should never make life difficult for our patients. Eat little bit of this at 4 o'clock, this 2 grams of this. No, none of that. We make it as livable. They have to live with it. It has to be doable, and the production value has to be less. I hope, is there anyone who wants to talk about this?
Another question, like PCOS, like where there is no access in hostel, like any kind opportunities for regular exercise can be challenging. How can these issues be effectively addressed?
When we thank you for that question. When we say exercise, actually we stop using that word, physical activity. It can be anything from there. No, don't take the elevator, take the stairs, walk to the mess. If they're in the hostel, they have to walk to the mess, right? And then you walk to your classroom, take the stairs, go for and then in the campus, go for a walk, get a bunch of other girls with you, all of you go for a walk, do some yoga, and cut down screen time, because it has been shown that TV watching increases the risk of weight gain in children and adolescents, because one, it takes you away from physical activity. Second, you're sitting in one place. Third, all the advertisements. So what will happen is during the ads, they go to the fridge and bring out something and eat, because you're tempted to go and do that. So all this contributes. So cut down. So behavior modification. No TV. Is it necessary for every PCOS woman to avoid soy and dairy products? Absolutely not. See, soy products have phytoestrogens. That's the rationale. The phytoestrogens, already women with PCOS, we know that they are high in estrone and all that. So what we want to do is everything in moderation, but nothing is a no-no. And dairy products, no girl should be without a dairy product. Why no USG for 8 years? Yes, in that time is when, see, many girls are already anovulated. So there may be those, there's immature follicles that might give a false picture on the one hand. And on the other hand, the atretic follicles and the increased ovarian stroma might not have developed yet. So you can overcall or undercall. So best is to just say at risk for PCOS. That's the diagnosis. And after 8 years, do the ultrasound and make the diagnosis. So as a dietitian, ma'am, how many kgs of weight gain during pregnancy can be considered within the normal range? So that depends on the mother's BMI. If she has a normal BMI, 18.5 to 23, somewhere between 10 to 12 kilos or around that is fair. If she's underweight, she can go even 15 kilos, or depending on severity of underweight, even more. But if they start going into the obese range, up to not more than 8 kilos, because they've shown that the baby's weight plus the uterus enlargement plus the fluid, the amniotic fluid, plus the breast weight and the fat weight, all of that is only 6 kilos. So we don't need to gain much more than that. As a dietitian, ma'am, it's very difficult to convince a patient to change your lifestyle unless and until they understand the importance of nutritional food choices. Very, very important point. I fully, completely agree with you. Doctors and dietitians have to be on the same page and work together. I mean, we are a team, and that synergy has to be there. And only then that will happen. I have to tell my patient, you have to listen to Tanuja. She's going to tell you, give you the diet, and please follow that. And so I have to endorse that. So this has to come into their head also. And I don't know, this is Nilisha. I don't know if Nilisha is a young person or a senior person, but I just want to say, just like doctors and patients, right? I keep telling it's like teachers and students. If the student likes the teacher, they will do well in that subject. So if a patient likes me, they will follow my instructions. So I always try to endear myself to them. I learn about them. I ask about where they are working, what their family is like, their likes, dislikes, hobbies. I learn about my patient so that there's a personal rapport. So you also have to build that to be able to get them to listen to what we are saying. GDM and bed rest, no bed rest. No bed rest for any patient unless the obstetrician tells them because of obstetric indication. But otherwise, it's the number one enemy for glucose control. How to correct constipation? More fiber. If that doesn't work, I mean, more water, fiber. If all that doesn't work, there are some, gentle fiber laxatives that pregnant women, can be given. But constipation can be a big problem in pregnancy. How can PCOS women reduce hirsutism and abdomen breast region? So typically, if their male hormone levels are high, we give them a combination of oral contraceptive pill and anti-androgen like spironolactone and or finasteride or cyproterone. Nowadays, there are very good lasers. People can go for that. I usually recommend it after these levels have been brought down. Then the lasers work better. And of course, you can also go for bleaching and waxing, and depending on how severe it is. So usually areas like abdomen, breast, and all that, they can we use these medications, and then they can go for some waxing and then laser if for permanent removal. That's all you can do. If the hirsutism is severe, no, I didn't mention it today, but PCOS is a diagnosis of exclusion. You have to make sure that the patient is not having Cushing syndrome or congenital adrenal hyperplasia or a androgen producing tumor or something like that that's causing excessive problems. So it's always a diagnosis of exclusion. Can you please repeat the point that you have mentioned? Recommend not to recommend insulin test. Definitely no insulin test. All of the professional societies have firmly said, because if a person is obese, their insulin level is going to be high. Second thing is, we only use metformin if their glucose tolerance is abnormal, or recently they've said it can be something in PCOS women can be tried in obesity. So what is an insulin level going to? We should order any test only if it is going to change our direction of treatment. And it's not going to change our direction of treatment. Okay. Okay, great, Sripriya.
Thank you so much, ma'am. Let me invite our President Sharon Thomas to give vote of thanks.
Thank you so much. Apologies for going over time.
No, ma'am, you have done a wonderful thing. Sharon Jishi?
Yeah. Good evening, everyone. On behalf of Community Nutrition Forum, it's my privilege to deliver the vote of thanks to today's Dietopedia session, the intersect session of PCOS to GDM, the challenges in maternal health. First and foremost, I extend our heartfelt gratitude to Dr. Usha Sriram for her insightful session. She beautifully highlighted the need of a paradigm change, a shift in women's health, actually emphasizing that the good health cannot bring overnight or only in the pregnancy. The critical role of nutrition, the growing challenges of NCDs, importance of weight reduction, lifestyle modification, and so on. And addressing the consequences of pregnancies were also the key takeaways. The PCOS was like, it's really like, what are the, the dietitian, what are the precautions we also have to take. It's really a enlightening session, ma'am. I also thank Dr. Krishna Sriram for referring Dr. Usha to our forum, making this enriching session possible. A big thank you for all the participants, your active engagement, which reflects the commitment towards learning. My sincere appreciation goes to the Community Nutrition Forum team for meticulous planning and organizing partners for the support in making this event success. Thank you all, and we looking forward seeing you in our future session. Thank you. Good evening. Have a great evening. Thank you.
Thank you all. Yeah.
Thank you so much, everyone. Have a wonderful year end. And Happy New Year to all. See you in next year, like 2025, with the fresh Dietopedia sessions. Thanks for the participation.
Thank you.
Thank you,
Everyone, Happy New Year.
ma'am. Bye-bye.